Good afternoon. My name is Allison Bernstein, and I'm the director for the Institute for Women's Leadership, and I welcome you to the second in a series of directors' dialogues. Today, we could not be meeting at a more propitious moment for women's health. I don't need to remind anybody in this audience that in the last week and a half, 2 weeks, there has been quite a remarkable outpouring of concern, protest, indignation around a number of issues related to women's health, including breast cancer screening, which has been done by the Susan G. Komen Foundation. But that's just the tip of an iceberg of a much bigger and broader set of concerns that bring us together today. And it really is my pleasure to be the host to have a conversation with Dázon Dixon Diallo and with Terry McGovern. All of you probably saw the flyer that announced this event, and I'm not going to repeat what the flyer said. So I'm going to give you a very brief summary that, in my mind and in the minds of my two colleagues, pretty much sums up who they are. Dázon Dixon Diallo is a graduate of Spelman College.
Yay! Because I knew none of y'all were going to say that, son.
Okay. I have to say that for me, Spelman College was home a year ago. Before I came to Rutgers, I had the honor and privilege of being the William H. Camille Cosby Endowed Professor of Women's Studies and the Humanities at Spelman College. Wow. I knew Dázon before. In fact, our paths had crossed. But nothing like being down in Atlanta and seeing her work. Dázon has a master's in public health, and I think it's fair to say that she is a trained public health advocate. She's also an inspiring activist whose focus has increasingly zeroed in on issues of women's health, but even more specifically, women's sexual and reproductive health. Dázon flew in yesterday from Atlanta, and we're really thrilled to see her. I think it's fair to say you haven't been to Rutgers in probably 20 years? At least. So it's great to have Dázon with us. Now, to my immediate right is Terry McGovern. Terry is a senior program officer at the Ford Foundation, working in issues related to women's and human rights with a focus on HIV and AIDS. She also happens to be the person at Ford who recommends the funding for Dázon. Is that fair to say? Along with Margaret Hempel, who's sitting in the second row, raise your hand, the director of sexuality and reproductive health work at the Ford Foundation in New York. Both Terry and Margaret are here to be with us, but especially I want to thank them as a former colleague. It's good to know that they're still at the Ford Foundation. Terry is a human rights lawyer by training, an activist by temperament, and she has chosen to become a philanthropist so she can make sure that more work that needs to be done gets support. Here's how this event's going to happen. I'm going to join my colleagues over there, and I have a few questions that we've all agreed that they would start to answer, and then we'll go back and forth a little bit. I'll keep track of the time, and we will then open up the floor to your questions. And I hope you're framing some questions right now, and if we don't answer them in the course of our conversation, please don't hesitate to raise your hand, and I'll call on you. Most importantly, we are going to be taping this and also filming it. Dázon told me, and I had forgotten this, but now I remember, for 19 years you have had a radio show in Atlanta. And so you're hoping to take some of what we talk about today and put it on your radio show.
Yes.
So this is Rutgers, New Brunswick, beaming to Atlanta, Georgia, eventually, right?
Yes.
We're not streaming right this minute, are we?
No, you will be in a few weeks.
In a few weeks, okay. So, women's health is a huge topic. I mean, frankly, when you want to sort of try to parse it, to try to understand it, there are so many issues. There are the disparities between women and men in terms of prevalence of certain kinds of things. Diabetes, for example, or obesity, or what have you. There's the question of women and heart disease. And more women, I'm told, die of heart disease than any other malady. Why reproductive health? Why are you both so concerned about reproductive health when, in fact, there could be so many other issues related to women's health? Who wants to start with that? Dázon.
So I can start with I get to talk about sex every day.
That's not why.
Y'all are laughing. No, it is the best part of the work. No, there's something about the fact that sexual identity, expression, sex itself is the cornerstone of everything. Even when, and I mean that. Why? It's how we all get here. I mean, it's the first thing. And when I was, growing into my, feminist bona fides or whatever, one of the things that kept striking me was, but for the fact that women can get pregnant and bring forth life, we would be seen as equal. And because the other half cannot, no matter how much they think about it or wish they could, cannot bring forth life, which is why I think that they're less committed to protecting it, cannot bring forth life, that's the one place that will be the last, the first, and always the battleground. Not my heart, not my brain, not my stomach, not my gut, my uterus is the last, the first, and the final battleground for any and everything. And if I do not have the full human dignity and autonomy to control that most important part of my capacity on this planet, then we're not going to survive as a people. And that women will continue to lose on all fronts. All fronts. Why is it that even with heart disease, we are just learning in the last decade or so that women experience heart disease and heart attacks and cardiovascular events differently from men? Because of your sex. Why is it that we weren't familiar with the intense levels of disparities in breast cancer? Because breasts were meant to be enjoyed by other people. They weren't even about my own sense of health and well-being and dignity. And that's because I have them and you don't. So everything does begin and end with our sex and sexuality, and we can tie just about every single decision we make. Just about every single decision we make in one way, shape, or another back to that particular capacity. And so that's why it became important to me that if I was on my campus and for some reason I couldn't get access to birth control on campus, or it was the only thing I could get, I couldn't get an HIV test on campus, or as I graduated that I could not get all of my health care in one place because my uterus had to be taken care of over here and everything else had to be taken care of over here. All of those things pointed to why this was important to me.
Terry.
I agree with everything that Dázon said. I was thinking about when we started kind of advocating with the FDA, why are you keeping women of childbearing potential out of the early phases of trials? They said because we have to protect the fetus or the woman to become pregnant. And when you actually started to look at, had they studied these compounds, did they know? In many instances, they had actually studied them and they knew that were the woman to become pregnant, it wouldn't hurt the offspring. So it was a completely disorganized, ridiculous system. So I feel like, this excuse around reproductive, protecting the unborn becomes just a huge excuse for misogyny on many, many levels. And when you really get into science at all its levels, that's what was so interesting about HIV. I never intended that to be my field, but it turned out what we were seeing in those women was just a microcosm of what was happening in women's health. We don't know much about menopause still. There's all these areas that are kind of rife with unknowns and lots of prohibitions based on things that actually aren't scientifically sound. So.
Let's break down sexuality and reproductive health in terms of disparities among groups of women. So I would like each of you to talk a little bit about your own work and trying to understand how differential impacts affect different groups of women. Will you talk a little bit about sexuality and reproductive health from the point of view of health disparities among women?
Ooh, Allison. A to Z. I'll talk about 3 specific things. And I'll end on HIV because that's the one where we have, I think, the most concrete data that also incorporates all of the other issues. But let's start with abortion, for example, as an issue of sexual and reproductive health and disparities. I don't know if you all are familiar, but over the last couple of years now, starting in the spring of 2010, the far right have managed to isolate out populations to target for anti-abortion mobilization and advocacy and shifting culture and conversation in ways that they hadn't been able to do before. And then we call it the Black Anti-Abortion Campaign. They started putting up billboards targeting Black women specifically. They started in Atlanta with 80 billboards that says, too many aborted, and had a beautiful face of a child. And on the billboard that showed up in New York, and I can't remember the actual caption because it was so traumatic, I probably forgot it. But there was a caption that ended up, I think, somewhere in Soho. It only took a couple of days to take that one down. It took us months to get them down in Georgia. That said, the most dangerous place for an African American child is in the womb. There are all kinds of these billboards that have been going up one by one, city by city, all over the country. Now, they're doing this because they're using data that says Black women in America get more abortions than anyone else. And so if we're going to end that practice, then we need to target Black women. Now, some of that data, depending on how you slice it, y'all know, you can look at it any kind of way and make an argument a lot of different ways. But when you look at it per capita, some of that actually is true, where especially women who are low income or poor, and even where they don't have the ability to afford abortions, would choose abortion more simply because, and there are no simple answers, but mostly because of all of their circumstances, not because they were willy-nilly about getting pregnant and then decided not to have it. There are all kinds of circumstances, including education, sexual education, relationships, intergenerational paradigms, culture, communication, poverty, all of those things play into whether or not to first decide to have protected or unprotected sex and then to have a child. So there's all kinds of reasons why we can look at why people choose abortions, and we've learned that convenience is not it for Black women. We just learned that, right, Margaret? So we've learned that convenience is not the reason that Black women are choosing it, and we have to look at all of those other issues. And what we do know is that who are the poorest people with the least wealth and least net income in this country? Black women. Who are the folks who are, if you lined up everybody in terms of pay equity and income for the same job, get paid the least? Black women. So there are all kinds of disparities that already happen before we talk about our sex and sexual reproductive health and abortion. I think a second issue, for example, would be around STDs. And that for Black women, we actually are disproportionately representative in gonorrhea, in the ridiculousness of like something of 60 or 70% nationwide. Chlamydia, we're even higher than that. And also, even though it's leveled off and it's controlled, syphilis and other sexually transmitted diseases. And those disparities are related to our history of experience, right? To our lack of access to healthcare, both or all during slavery, during Jim Crow, and during the post-civil rights era when healthcare became so expensive. So there are all of these other issues that are related. And then there's HIV, which falls right in with STDs, but is a little bit different because there are so many other human rights frames at play when we're talking about stigma and shame and discrimination. So there are historical reasons, there are socio and economic factors, there are cultural factors, And in large part, there are even relational factors. For example, of all of the groups of women, heterosexual women in the United States, black women are the least likely to date or marry outside our race. So if we already have a larger concentration or a higher concentration of disease burden in our populations, then we have fewer opportunities to protect ourselves in the context of not having a whole lot of sex with people outside of the black community. It's like if you make the pool smaller, then the opportunity to get caught by the shark is bigger, right? So those are a lot of the different reasons that lend themselves to the disparities. And I think the last one that I would lay on the most seriously, I think, is black women's sexuality and the history of its abuse, of its objectification, of our subjectification, the fact that for hundreds of years we had absolutely no control over anything around our sex or reproduction, that even post-slavery we still have very little control because we went then from being human chattel to belonging to men in our lives and having no choices then. And also, of course, having years beyond everybody else as women to have the right to exercise our political freedoms and our votes and all of those sorts of things that might help impact policy, right? So the disparities didn't just happen because we were able to count the disease better in the last, 50, 100 years or so. The disparities have been happening since we were brought ashore. So it's not like it's a new thing for us to understand. Why are these things so terrible, particularly for black women?
Terry, do you want to?
No, I don't have. I mean, except to say that, the reproductive justice movement has raised all these issues, but as we were discussing before we came in here, there's not a lot of kind of advocacy, activism, taking up these issues in the traditional women's rights movement.